Welcome everyone to our monthly webinar. This is Ben Knoll. I'm the Director of Patient-Centered Research for the Global Healthy Living Foundation, also Principal Investigator for Arthritis Power Research Registry. We're delighted to be bringing this webinar to you today. It's in partnership always with our Autoimmune and Systemic Inflammatory Syndromes Collaborative Research Group, so other conditions, other patient networks like ours for other conditions such as vasculitis, multiple sclerosis, inflammatory bowel disease, both pediatric and adult conditions. So thank you so much, everyone, for joining today. A couple announcements before we get started. One is I wanted to wish everyone a happy Arthritis Awareness Month, which happens every May. So this is a very fitting topic for this for the webinar this month. And a couple of reminders. We keep control of the webinar on our end so that there aren't interruptions and so things go smoothly. And we would invite you to submit questions in the GoToWebinar dashboard under questions. You can type in questions there. If it's easier to do it in chat, that's also fine. And then I'll come back on at the end to facilitate some Q&A with our speakers this evening. And you should also know that we record these webinars. So this is being recorded, both the visual and the audio. And we post the recording with a little summary of the webinar within 1 or 2 weeks of today. So if you have to drop off early or you know someone who missed it, they can still benefit from the information by viewing the recording. So with that, I would like to welcome our speakers. The topic, the webinar description today is what is shared decision making and why is it important? And our two co-presenters are people that we have worked with, some great partners and friends that we've worked with over the past few years, basically ever since the beginning of our research work and Arthritis Power. So first we have Leanna Frankel, Dr. Leanna Frankel. She's an adjunct professor of medicine at Yale University School of Medicine and director of patient-centered population health research at Berkshire Health Systems. Her research focuses on developing methods to measure patient preferences, facilitating shared decision-making, and improving methods of risk communication. And our co-presenter is Carol Wiedmeyer, who's a co-investigator on many of the studies that we work on with Dr. Frankel. And Carol is an experienced researcher who brings her perspective as a rheumatoid arthritis patient to her work in patient-centered healthcare research. She also served for 2 years as a patient governor with the Global Healthy Living Foundation's Arthritis Power Initiative. So with that, we're delighted to have you, and I'll turn it over to you, Leanna, to start.
Okay, thank you. So just in terms of our disclosures, the work that we're going to be presenting was funded by the Rheumatology Research Foundation as well as the NIH. And they are not responsible in any way for the data that we're going to be presenting. And Carol and I have no conflicts of interest with respect to the material that we'll discuss. So first of all, just so that we're all on the same page, what actually is shared decision making? So in this context, what we're referring to is a process where your doctor or other healthcare professional describes all available options to you and then discusses the individual benefits and risks of each of those options, facilitates a discussion where you and your healthcare provider can discuss the pros and cons, think about what's most important to you, what you prefer, and together then come up and decide which is really the best path for you to take. Importantly, there's been quite a bit of research now on shared decision making, and two big meta-analyses that have basically summed up all the clinical trials in this area have shown that compared to usual care, if you actually implement shared decision making, it improves patient knowledge, it can enhance patient confidence in their decisions, can strengthen the relationship between doctors and their patients, and it actually can improve health outcomes by improving really patient empowerment and their ability to participate in their care. And although there aren't a lot of trials showing that, it has been shown in lupus as well as diabetes, for example. So what does this actually look like in clinical practice? Well, there are several steps that can be taken. And so the first one we talk about is actually something called choice talk. And this model was developed by a researcher originally in the UK and now in New Hampshire, named Glenn Elwyn. And choice talk basically is when your healthcare provider, your PA, your nurse practitioner, your physician, basically puts all the choices on the table. And that actually, we learned, is the step that is missing the most often. So typically, very frequently, a doctor will say, well, okay, things aren't going well, this is what you should do next, or I recommend you do this. So we don't actually frequently give people choices, and there are a lot of reasons for that. But once choice talk originally, ideally is given, so all available choices you are put on the table, then what happens next is option talk. And option talk means that you really go into detail about each of those options and to talk about what all the potential benefits are of each of those options and what all the potential harms are of each of those options. And as you're doing that, you're really trying to have a back and forth listening to your patients about what is important to them, right? So we need to actually ask our patients, and that's what we mean by elicit values. This is an ongoing back and forth process. And so, if a doctor doesn't say what's important to you, and it's really up to you to sort of chime in and start asking questions. And then once all that information is out there, then you need to deliberate and say, okay, I'm educated now about my choices. I understand what the pros and cons are, what best fits with my preference. And ideally, you come up then with a choice that is concordant with your values, and ideally, then that choice is actually implemented. So as you've seen just from that previous slide, this is not something that takes 2.5 minutes. This actually takes some effort and time, and we couldn't possibly do that with every single decision that we face in healthcare, right? So when is this really most important? So you can think about decisions in 4 different boxes, like we see on this slide. In the upper corner, you can see that we have decisions that might be high risk, but also associated with high certainty. So, for example, surgery for a gunshot wound, right? For that, it's not time to start thinking about all your options. Really, there's one option, right? So, we're not going to deliberate about all the potential choices because there really aren't any. And the appropriate thing to do there is to really just get informed consent, right? So, do you agree to go have surgery for your gunshot wound? Sort of end of discussion. Similarly, you could have low risk conditions, but that also have high certainty, right? So, for example, your blood pressure is not controlled on this medication. Our guidelines recommend this, right? Do you agree to that given the potential harms of this medication? And again, there in many, many cases, it's a process of informed consent, and it's not a matter of dealing with the pros and cons of various different options. Although as more drugs get developed for blood pressure, that might become the case. But then we have decisions, both high and low risk, that are associated with low certainty. So on the other side of the graph, you can see here that breast cancer decisions, for example, right, you not only need informed consent, but you really want to know whether a woman wants breast conserving surgery with radiation, for example, versus more radical surgery. So that would be a clear case for shared decision making. Total knee replacement for this audience might be a similar situation where clearly patient preferences are really very, very important. And these don't all have to be high stake decisions. You can have low risk decisions, but also that have low certainty, such as for many people, whether or not they should use diet or drugs for high cholesterol. We have here hyperlipidemia. So basically, the bottom line is when it is clear what to do, there's a clear dominant path forward. Like, should we stop smoking? Should we exercise, right? Should we have surgery for a significant wound? How to treat a heart attack in the emergency room? Do I need a cast for this fracture? Those are not the type of decisions that we're talking about tonight because there's a clear way to go. But any decisions when there is more than one choice, and that choice might be to stay with the status quo, right? So it might be, do I want total knee replacement surgery or do I want to continue with what I'm doing? Those are 2 reasonable choices. So as long as there's more than one reasonable way to go, and there's uncertainty, shared decision making is appropriate. So what we got started on working on was shared decision making and treat to target. So why? Well, treat to target in rheumatoid arthritis and psoriatic arthritis and probably lupus really requires a shared decision-making approach because of as many of you know, there are frequent decisions to be made, and they're basically conditional on patient preferences. Why? Because there's always more than one choice. One of the most common types of decisions that we face is in patients who are initially treated with methotrexate, for example, and have done well, but maybe not well enough. And then they might be facing, depending on if they have any contraindications to medications, they might be facing, choice up to 12 choices in some cases. So that's why we wanted to look at treat to target and developing ways to implement shared decision making in this complex decision that many patients face over and over again. So unfortunately, despite the fact that we all believe that shared decision making is a wonderful way to go, I say it's like basically we always laugh. This is like apple pie. Of course, we would want to do this. All the studies that have looked at whether or not we do this in clinical care have shown that patients are really very rarely effectively engaged. And there's a lot of reasons for that. It's hard. It's hard to do. It takes time. And it's probably much easier just to make a single recommendation, but that's not necessarily the best care. In terms of how we might implement the model we talked about before, you can see here that in somebody who's not doing well on methotrexate, the example we just gave before, ideally, you would give all the potential options to that patient and put them on the table. And you can imagine then you'd have to think about talking about the pros and cons of all the other traditional DMARDs like sulfasalazine and hydroxychloroquine and leflunomide or Areva. You'd have to think about talking about 5 different TNF inhibitors now, such as Humira or Enbrel. You'd have to think about abatacept or Orencia. There are now 2 IL-6 receptor inhibitors, tocilizumab and other ones. Some of you have heard of rituximab. And there's an increasing number of the JAK inhibitors, which are the pills, otherwise known as the small molecules that we now have available. And they keep coming. So can you imagine talking with your doctor about all the pros and cons of each of those? It would quickly become overwhelming. And so we had to think a little bit outside the box.
Okay, I guess I'll pick it up from here. Thank you, Leanna. Hi, everybody. It's really great to be here. I appreciate everybody showing up. So what I'm going to be talking about in the next few slides is about a study that Dr. Frankel and the folks at Creaky Joints and I engaged in a few years ago now. And we did some research to really take a look at how we might be able to effectively change the task. You saw on the previous slide all the different possible medications that a rheumatoid arthritis patient might have to consider or discuss with her doctor. And here we decided to take a little bit of a different tack and do a study to see if we could come up with a way for patients to talk about what matters to them when picking a medication. And then, as you'll see in the subsequent slides here, how we use that to develop a tool to make it easier for patients and doctors to quickly narrow the field in terms of what medications would best potentially align with their values. So to give you a brief overview of the study here, we set out first to measure rheumatoid arthritis patient preferences. So what was important to them when they were looking at a medication or switching medications? So we did an online survey with 1,314 patients through Creaky Joints, and it was fielded both in English and Spanish. And I will say, before we even did the online survey, we had an online webinar and some online discussions and some phone interviews to really try and dig deep into what are the concerns that patients have when they're choosing a medication. But then we got to the point where we're doing the quantitative survey. And as a result of the survey, we were able to create 5 distinct groups of patient types based on what matters to them. And then from that, we translated those results into a brochure that was designed to be user-friendly, something that patients could get a hold of in the doctor's office and use to facilitate a discussion. And then Leanna is going to talk about how that brochure was tested in the real world in a clinic setting. So that's an overview, and I'll get into some details on the next slides. And we can go to the next slide.
I'm trying.
Thank you.
Okay.
Perfect. So some of you may even remember this study. I know some of you helped us test it or may have taken the survey. This is just one example of how we were able to dig into what it is that matters to patients when they're picking a medication. So this is an example of a survey question where we asked people to say, if these were your only options, these three things here, option 1, 2, and 3, which one would you choose? And you can see there's this column on the left, it says medication facts, and it's got all of these different aspects of the medication. There's how it's administered or how you take it, whether it's pills, injection, or infusion, how quickly it starts working, what kinds of bothersome side effects you get, more quality of life oriented ones, headaches, stomach problems, and the like. And then the more serious side effects, infections, very rare, potentially life-threatening or permanently damaging side effects. The information available, which really has to do with how much information is available due to how long something has been on the market, and then cost or affordability of the medication. So in the survey, we presented these types of questions kind of over and over and over again to each survey respondent. And as a result of this type of a methodology, we're able to discern what's important to people. For example, if you really, really hate doing injections, you would avoid picking option 2 at all costs, no matter what the other things were. If it was expensive, if it had higher risk of side effects, from that we can sort of see behind the scenes that that's important to you. Okay, so we can move on to the next slide. So as a result of that study, this is really the big thing that we found from this. And I'll explain this because it's a little bit of a busy slide. So here we have 5 groups of patients. So from the 1,300 and some odd patients who took our survey, they basically all fell out into one of these 5 different groups that you see here. So each group has a number of different bars, and the bars all represent some feature of the medication. So if we look at the group on the far left that says in green above it, bothersome side effects, this is the group for whom the bothersome side effects, the quality of life issues, that, the headaches and the stomach aches and so forth, to those people, this was the most important thing. And the reason we can tell that is that the third bar, the green bar, has to do with the importance of that particular feature of those types of side effects. You see, the other bars and the other colors for this group are much lower. For example, the red bar on the far left, having to do whether it's a pill or an injection or infusion, is very, very small. It means that those people will take anything as long as they can avoid really getting away without having too many quality of life side effects. The other groups care more about other things. So the next group over, onset of action, this is how quickly something starts to work. These are the people who really want something to start to work right away. They've been in a lot of pain, they have a lot of disability, they've been that way a long time, and they're ready already to have something to start working for them. The next group, as I described earlier, these are the people who really want to avoid needles if at all possible. And then the second to last group in purple, these are the people who, they care about other things as well, but they mostly care about the chance of a very rare side effect that could be very debilitating or potentially even deadly. And so they'll really put up with a lot of other things to avoid a medication with that particular possibility, even if it's very, very rare. And then on the far right, you see the group of people for whom cost is really, really the big driver. And one thing I'll point out is that along the bottom of this graph, and I'm pointing, I know you can't see my hands, but this is the largest group. So you can see that 38.4%. Thank you, Leanna. I forgot you had a pointer. So this tells us that cost is a huge factor for people, and they will definitely put up with a lot of other things if they can just find a way to afford their medications. And then the second largest group is on the far left. Those are the people whose decisions are often driven by what we are terming the bothersome side effects. The people who want to avoid needles at all costs, they're the smallest group in the middle at 6.8%. Those are the people who are quite firm, do not want to go that route if they can avoid it. Okay,
So, you know what, just before we go to the next slide, I just want to point out something here as a clinician that I found very interesting. We frequently spend most of our time talking to our patients about these side effects. So we assume these are going to be the most important to people, the very rare side effects. But what's interesting to us is what patients really felt was important in terms of what drug they would choose is the bothersome side effects that affect their quality of life. And that the reason that's important is that if patients don't bring these up, doctors tend not to discuss them. And the reason doctors tend not to discuss them is because they're not health threatening. So even though they might significantly impact our patients' lives, we worry about these more, even though they're rare because they can be more serious. But what really just affects people much more commonly is the stuff that doctors tend to care less about because they're not threatening to your health. So that's just really important for patients to continue to bring up with their physician. So, you know, to remind them, hey, doc, you know, it might not be serious if I'm nauseous, but it really, you know, makes me pretty miserable. So that was also something that we learned from this study.
Great, thank you. And then also, and we can talk about it on this slide, the other thing that clearly popped up is the issue of cost, right?
Yes.
So we'll talk about that on this slide. So as we mentioned earlier, this study then resulted in the development of a brochure to use in clinic. And the idea here is this is something that could be handed to a patient, and she could review this perhaps in the waiting room, and then bring it into the exam room and have a discussion with the doctor about, you know, basically which one of these groups most closely matches how they think about RA medications. And we realize, of course, that not everybody is going to neatly fit into any particular box. And, you know, really that's fine. The idea behind this was just to facilitate the discussion and maybe hone in more quickly on what are the concerns of this particular person. And then from there, the doctor could kind of narrow down the options. So as you can see here, we illustrated in the row that says our top priority is to. So the orange group is to avoid the side effects that impact quality of life, as Leanna was just talking about. The tan group is making sure that they, you know, get onset of action as quickly as possible. The blue group is to avoid the needles. The yellow group is really to, you know, avoid those very serious but very rare side effects. And then the last group, the green group, the largest one, to be able to afford the medicine. It doesn't mean that other things don't matter to them. And one thing that is kind of interesting to look at here is that affordability actually is important to everyone. It comes in kind of second place, you know, below the top priority for groups 1 through 4 there. And then, of course, it's the number one thing for the last group.
Yeah, so that's the blue bar here. You can see is what Carol just mentioned here, the importance across the groups.
Yeah. Well, maybe not second place, but it definitely pops up quite noticeably for everybody. And then the other thing that I thought was kind of interesting here is that side effects that impact quality of life, which are the number one concern of people in the orange group, those actually come into the other things that influence our decision for all the other groups. So those two things really were pretty big drivers across the board, but it was really just a matter of determining what is the number one thing for people. And then the things that people paid, you know, less attention to had to do with how long the medication had been on the market for the most part, and some of the other items that are mentioned at the bottom of the slide. And then the other thing I just want to point out here is we heard a lot of verbatim stories from people, both in webinars and then in surveys people typed in comments, and we pulled out some illustrative quotes here. And then regarding the green group on the far right, the one that is really concerned about being able to afford the medicine, it turns out it's not totally people who are underinsured or uninsured or have high copays or, you know, high deductibles and that sort of thing. It's this atmosphere of uncertainty that we're currently in, where people are not really sure what kind of a deal they're going to get for their insurance in the coming years, and whether their medications will continue to be allowed or on a formulary, or just exactly what will continue. When you have a chronic illness, you obviously want to plan for the long term, and that we're not in a situation right now where that's really easy when it comes to financial planning with these very expensive drugs. So this is another thing that is not discussed, or not discussed very well, I would venture to say, exam room, right? Doctors are not necessarily the people who are the best informed about the nuances of everybody's particular insurance plan. And so this really speaks to a need as well, I think. Okay, and then the flip side of this brochure, of course, then takes those groups and according to what it matters most to people, and lays out some recommendations. These are recommendations based on the main medications that were available at the time of the study, which was done a couple of years ago now. But as you can see here or there, I'm not going to go through each recommendation, but obviously the green group, the cost concerned group, consider the most affordable options first. The blue group, the people who want to avoid needles, recommend taking pills, and so forth. So as you can see, this type of a decision tool or decision aid can help to focus the discussion in the exam room and allow doctors and patients to have helpful, productive discussions and make the best kinds of decisions. So I'll turn it back to Leanna now, who's going to talk about how they actually took it for a spin in the clinical setting.
Perfect. So we want to see, can this be used in the clinical setting at the point of care? So everybody knows that the office visits, depending what day you go, can get pretty harried, and you only get so much time with your physicians. So we were really interested in, what happens when you actually put this brochure in the hands of patients in the clinic. So what we did is we did what we call a pre-post test design. So we first audio taped a lot of patients with rheumatoid arthritis talking with their doctors in regular outpatient visits for several months. And then, as per usual care, without anything happening. And then we stopped and we gave the doctors the brochure, and then we audio taped a bunch of visits again as we move forward for the next few months. And we looked at how things went before without the brochure and then after with the brochure. And the only training we gave doctors was really 20 minutes to show them how to use the brochure. So it's pretty easy to use, which is important because if you want to sort of send this off around the country, it's got to be pretty easy to use. We got informed consent for all patients to be audio taped and to be part of the study. And many of them reviewed the brochure before seeing their doctor while waiting in the waiting room. Most of the patients were female, and you can see the numbers there, 40 in the pre out of 46 and 33 out of 40 in the post. Most of them were white, but not all, 33 out of 46 in the pre and 25 out of 40 in the post. And the remainder of the patients, where this was done in New Haven, the remainder of the patients were divided between Black and Hispanic. The mean age was about 58.3 in the post and similar, in the pre and similar in the post. So was the brochure used? So the good news is the brochure was used a lot. Now you'd think that that's a no kidding, but I can tell you I've done other studies where we've given patients pamphlets and they've promptly put it in their back pocket and actually did not bring it out to use it with their doctor. So this brochure, we learned you have to make it big enough and colorful enough, and you have to actually prompt the patients to say, it's okay to bring this up with your doctor. Because if they're sort of not given a prompt, then they get sort of put in the purse or the back pocket. What was interesting is similar to what Carol said before, is that patients tended to use the brochure, but they identified many of them with more than one group. So many of them said, this is really important to me, but so is this, and would point to another column, which was fine. And only 3 out of the 40 that we had in the post group, only 3 really could not identify with really anything on the brochure. So most people were able to say, this is similar to how I feel. I match up with this group of patients, and found it useful. In all of those patients who used the brochure, they found it was helpful to clarify their values, that is what was important to them, but fewer used it to clarify actually a medication that they would take. So the brochure helped people think about what's important to them, but didn't necessarily help them choose a specific medication. So what are some more results? So if you look at the table here, so this is in the pre-test. In the pre-test, when we did not have the brochure, how many times did the doctor offer more than one potential treatment option? About just under half the time. In the post-test, when you introduced the brochure, more than one treatment option was offered 60%. So clearly, not 100%. We're still not doing as well as we should be doing, but there is a boost. So doctors, get away from, you haven't been doing well on this, take this one now. And they start talking about choices once the brochure is introduced. What happens in terms of patients actually telling doctors what's important to them? That's what we mean by vocalize their values. So how often do patients actually say what was important to them? And we measured this by listening to the audio tapes. So in the pre-test, when we did not have the brochure and only one disease modifying anti-rheumatic drug was offered, really just about half of the patients said what was important to them, really spoke up. In the post test, however, once the brochure is introduced, even when the doctor brings up one new drug, then you get really the majority of patients talking about what's important to them. So we were very excited about this finding. So the brochure seems to stimulate a discussion when one drug is presented. Because if it's not there, then only about half probably the more vocal patients, will speak up and say what's important to them. If you have, however, two drugs on the table, it's going to be more intuitive to talk about what's important to you. So there, even without the brochure, 86% of people are talking about what's important to them. And it gets a bump of 10%, but you can imagine if you're talking about two things, it'll be more natural for the conversation to involve what's important to you. And here, the discussion of what's important to you is almost always about how the medication is given, not about cost. Even though the brochure was all about DMARDs, we found that using the brochure also stimulated a discussion that involved patients' values when you talked about prednisone. So the brochure basically got patients and physicians talking and communicating better together. How often was the recommendation actually made based on patient preferences? So how often at the end of the visit did the patient walk out with a treatment recommendation that was clearly based on what was important to them? Just over half the time without the brochure, and every single time when you had the brochure. So, a couple of very important findings in this very preliminary study. This was really just a proof of concept. The very, very, very important news was that the average visit length did not go up when using the brochure. It actually went down by about 4 minutes. So this is something that's really important to clinical practices. Why is that? Well, we think it's because actually the conversation becomes much more efficient. So, as somebody who does this every week, I find using that brochure a much more rewarding way to have the conversation. Otherwise, the conversation can go off in tangents and you might never cover what's most important to the patient. It also helps patients buy into that fact that there's really no one correct choice for them. So some of you might be feeling on the webinar here that, it's much easier to go in and get a recommendation from your doctor. It would be really nice if there was one perfect choice for me, right? It is much harder to make a choice than to be given a recommendation. Life would be great if there was one clear treatment choice for each person or one for all of us, but it's just not the way it is. And so this brochure helps patients to buy into the fact, that there might be one medication that's better for me and one that's better for my neighbor. It might not be the same thing. Importantly, it tailors the discussion to an individual patient's concern. So once cost is on that brochure, if that's what's really concerning you, then it's very likely to come up in the conversation. It also helps patients feel less overwhelmed by the number of choices. So as you remember from the beginning, when we talked about you might have 12 possible options to go through, really without this brochure, I would think shared decision making would be much, much more difficult. So this kind of takes that, that task of weighing all the pros and cons of all of them and gives you instead sort of buckets of things to think about, at least to start the conversation. And very importantly, what we found, and Carol just brought this up before, and people might have some questions about this, is the quality of the shared decision-making conversation was significantly moderated by insurance coverage. And this actually ended up in another paper. So we found, very unfortunately, that people who have restricted insurance coverage really have very little option to participate in shared decision making, because for them, there's very, very frequently one option or no options. People who have really very comfortable insurance coverage, they're the ones who are most likely to be able to have a shared decision-making conversation because they have some choices. So the quality of the communication and the decision-making process with your doctor really depends on your insurance, which is, I have ethical issues about, but such as our healthcare system right now. So in summary, there is greater evidence of shared decision-making with the brochure. There's a trend with patients being offered more choices when we introduced the brochure. More visits where patients were able to vocalize their values. This is especially with respect to cost, because now it was on the brochure and doctors had no choice but to look at that because it's most important to most people. And importantly, providers were more likely to base recommendations on their patients' values. So that was the slide where we showed you that 100% of people left the office with a prescription that was concordant with what they thought was most important.
Okay, so thanks. I'll pick it up here. We're just about wrapped up, and we're really interested if you have any comments or questions. So please type those in if you haven't already. But just in summary here, what does this mean for us as patients, either with rheumatoid arthritis or other similar conditions where, you have multiple options and no one clear choice? Clearly, this is an arena where I think all of us could be more proactive, myself included. Our first bullet here is ask whether there are other choices. And boy, this looks so straightforward on the page here. I find this can be, as a patient, a little bit challenging in practice at times. Often what happens to me is I get home with a prescription and I look into it more, and then I end up with questions, and then there's a 2-week back and forth on the phone with my doctor's office trying to figure out if there are other choices. But really, bringing that up early and often when you're with your doctor, just to really even understand what you should be considering in the first place, is a great place to start if you're not doing that automatically now. Also, we recommend that you spend perhaps a little bit of time thinking about what matters to you and clarifying that in whatever way you can. I will say that in my particular case, when I was first introduced to biologics and I was contemplating doing self-injections, I had a very incorrect idea in my head about what would be involved in doing self-injections. And had I really clarified that with the clinic staff, I think I would have probably come to a decision a lot sooner, either talking to the doctor or to the nurse or to somebody in the clinic staff about really what's involved in dragging refrigerated needles around when you're traveling on business and that kind of a thing. There are decision aids out there, not a lot of them, but this brochure is an example of them, and there are others as well. I recently authored a blog post on creaky joints that has a list of some of them with hyperlinks if you're interested, that kind of leads you through an exercise to help clarify what matters to you. Instigate the conversation with your doctor about what matters to you if your doctor doesn't do that and is really just offering you one option. And there are other things aside from your primary medication that are definitely potentially on the table for this type of a shared decision-making conversation. Other treatments, physical therapy, vaccinations, alternative treatments, etc. Anything that has to do with helping you feel better really is something that could be discussed in this manner with your care providers. We also suggest that you take advantage of the clinic staff. A lot of times they are available, the nurses and the other, all the other people there, even into the finance office. They can help you navigate insurance requirements, help give you options for financial assistance programs. I know many of us already take advantage of those types of things, but we just want to make sure it's out there that sometimes the devil's in the details. You think you've made a decision in the exam room, and then you get out and actually implementing a whole nother ball of wax. So those are some of our thoughts on how you can implement this and take a little bit more control and make sure that the decisions that are made on your behalf about your care really reflect what matters to you, and ultimately, hopefully, give you a better result than would otherwise be the case. And that's it for our prepared slides. I think we made it in time. And at this point, we're open to discussion, comments, questions. Leanna, if you have anything else to say before we launch into that, feel free to chime in as well.
No, I think you summarized everything, Carol, beautifully. Thank you.
Well, thank you so much for that very clear and interesting, well-organized presentation. This was wonderful, a wonderful overview of shared decision-making, what it is, and an example of how to create an understanding of what's going on, the different options, and the different concerns or worries that patients might have, and a decision aid, an example of a decision aid for rheumatoid arthritis. So the first question is actually about that. I sort of indirectly comes from Shilpa, who was sitting right here and said, looking at the bar graph, that this is so good. I wish they'd make a decision aid out of it. And then, you know, lo and behold, of course, it was piloted and studied. So the question regarding that is how available is that decision aid that was developed, the two-sided one that was piloted with the 40 or so patients, and how will it be used going forward, or what's the plan for the next steps?
Right. So that is a fabulous question. And actually, as we were presenting it, I was like saying, like, maybe we should just give it to creaky joints. So, this was developed with funding from the Rheumatology Research Foundation, and in collaboration with Creaky Joints and Arthritis Power. As far as I'm concerned, it is very easy to disseminate. Right, this is available as a printable PDF. I have hundreds of them. I use them all the time, and I don't see any reason why this can't be shared as is. Actually, as we were just talking about this, I'm thinking, why can't we just hand it over? So there are two provisos. One, I'm personally willing to hand it over without any issue, and it could be available for people to download and print out, and probably to look as well online. The only issue, there's two issues in terms of sort of intellectual property that I would have to make sure with first, and that would be both with Yale and with the Rheumatology Research Foundation. So I'm happy just to do due diligence and find that out, but I see no reason why we can't make this widely available to patients.
Okay, great, thanks. And that's a follow-up question to that is, are there any doctors that are currently using this decision guide? I presume you are, of course, but I wonder if there's others that are still other clinics that are still passing it
no,
out.
not outside of our particular location. The other issue, the reason that so this was developed really as a proof of concept to look at preference phenotypes and whether you can sort of cluster patients as a easier way to have a shared decision making conversation. The issue with these decision aids, and I think this one actually can live a fairly long life because these values are likely to be fairly stable over time, but they need to be updated frequently because of all the new drugs that come on board. So with that caveat, this could be distributed, but unless somebody updates it, right, it will have a relatively limited sort of survival time. So the values are likely to stay stable, but there's more drugs that are available now that even were there when we developed this. And unfortunately, the cost to keep these going, it requires cost to do this. So we'd have to update it if we wanted to keep this on the website after a certain amount of time. Similar to treatment guidelines, they live for about 5 years, but things change over time in terms of what treatments are available. So with that sort of caveat, we could certainly disseminate it, but patients, we would have to put a disclaimer, that this was developed in a certain year and new treatments are constantly being developed and FDA approved.
Okay, thanks. And someone else actually wrote that as a stroke survivor with memory and verbal comprehension deficits, she wrote that she is definitely all for brochures, so printed visual aids, materials like this.
Oh, that's so, yeah, absolutely. Absolutely. Yeah.
So another question is related to more the logistics of communicating with clinic staff. So this patient writes that they found that with mergers of hospital systems, that insurance, paperwork, everything becomes a bit more complicated and overwhelming, and with healthcare options, and of course shared decision making is kind of part of that bigger conversation, I guess, about all types of healthcare options. And so the question is, do you find that online patient portal systems are a helpful way to reach out to clinic staff or to a physician? I guess that's the question here, but I guess I'm asking you to comment on how you as a physician use those kind of patient portal systems, and if there's a way to incorporate these kinds of decision aids into that platform.
That's a really good point. So there's sort of several layers of answers to that. One, it is very important to many practices for patients to use the portal system. So it's a measure of quality, and many practices are really encouraging patients to use the portal. So it's very helpful for short questions. I think to have an in-depth conversation, it would not be the way to go. But to prepare or to have decision-making tools on the whatever electronic health record or web-based system the hospital has is definitely being looked into. So it would be very valuable for a patient preference, for example, to be incorporated into the electronic health record. So if we could find a secure way for patients' preferences to then go right into the chart, so the physician had, what cluster you fell into or what's most important to you, whichever type of format you can imagine, that is definitely being worked on as we speak. The problems are always related to privacy, right? But having patient preferences in the record as a way to keep track of preferences and stimulate shared decision making is absolutely a wonderful idea and being looked into currently.
Great, thanks. That's good news. Yeah, it seems like as we, especially the work that we're involved with in Arthritis Power and in integrating patient-reported outcome data and information into electronic health records, that patient preference information would be useful to state there too.
It's also, doctors are also, if there's a way we can make that so that it's, time efficient and not another bunch of clicks, right? Because nobody wants to do that, being honest. It would be very valuable because it's a way to support shared decision making in practice, right? It'll just give you a roadmap. It'll make it easier and it's documented. So, I think patients would like to have the fact of, what's important to them documented in the chart.
Yeah, that's great. So a few other questions have come through here. First of all, how common is it for doctors to be trained in shared decision making? In the example, the proof of concept study, the small pilot study, it sounds like it was prompted, the doctors received a little bit of training, but it was really on the up to the patient to bring in the decision aid and bring that out with them to have the confidence. So I guess, kind of two questions here. How common is it for doctors to be ready and trained in shared decision making? And then how can a patient know if their doctor will support that sort of decision making process?
Okay, so there's good news and bad news there. So the bad news is that whenever this has been looked into, this happens in a minority of cases. So it is not common, and you will find shared decision making happening in practice around the US. It's not common. The good news is that this is now a thing. Medical students are now being trained in shared decision making. Residents, when they get into the hospital, as one of their core competencies on which they are evaluated, are being ranked on this. So they're expected to become proficient in shared decision making throughout their training. So at least it's now being talked about and discussed and evaluated during training. That's clearly not enough. And there are a lot of reasons why it's not enough. And I'll tell you very honestly, as a person who sees patients all day, Mondays and Tuesdays, the reason it's not done is not because doctors don't want to do the right thing, it's because it is hard to do and there is a limited amount of time. So the best way forward for this to actually happen is for patients really to come in prepared, for patients to ask what their choices are. Not actually, as I was thinking about that slide, we should have changed that first bullet. You shouldn't ask, are there any choices? You should say, what are my choices? Because are there any choices allows a physician to say yes or no. If you say, what are my choices? You can't say yes or no. So once you say, what are my choices? As soon as you say that, you are going to increase a millionfold the chances of having a shared decision-making conversation. That's the good news. And we learned that from our study. That's really all it takes, is opening that door. Once that door is opened, right, it's a whole new conversation because you derail the physician from saying, this is what you should take next. So once that conversation is opened up, it's a really good thing. There's also two types of decision aids out there. Really, there's probably more, but two big types of places decision aids have a role. One is where you don't have a rush decision. You can go home and think about things, right? To me, it is always better to go home and think about things. And the reason is nobody's ever made a good decision under duress. And if you have 8 minutes or 15 minutes with your doctor, right, and you're about to make a very important decision, you kind of don't want to be rushed in. You want some time to think about things. Right? So in rheumatoid arthritis, we don't want to take 3 months to think about things. We want to control the inflammation, but you certainly have a few days, right, to go home and do a decision aid at home if you want to, and then come back, do some reading at home. We're always giving our patients, reputable websites to learn from, and come back with the questions once you and your physician have come up with the reasonable options that you should read about and talk about after. And then people are also developing point of care tools like the one we just talked about that you can use right in clinical practice. We're working on another one now on an iPad that allows a patient to guide the discussion by clicking on questions that are the most important to them. So getting, really going for the most important questions first and getting pop-up answers as they go through. And patients are just loving this in clinical practice. We're hoping that a nurse practitioner or a medical assistant will be able to do it with them and then bring them into the doctor. So there's several challenges, but I think as people become, as we get more choices, and as this becomes just more normal for patients to take an active role in their healthcare, it'll become the norm, right? We just have to figure out how to get it done within the constraints of clinical practice now. I hope that
Okay,
answers the
that's
question.
great. But
Sorry.
yeah, and I mean, overall, it sounds like it's moving in a good direction, or you sound optimistic that it will become more common moving forward.
Yeah, and honestly, so it's becoming, it's becoming sort of what is expected, but honestly, it's just becoming more and more common for patients to ask, right? And I think patients are becoming much more active participants in their healthcare, and soon that will be the norm across patients. So then they'll drive and it'll be, mandated basically, which will be great.
Mm-hmm. So this is a question, we've got a few minutes left here, and I wanted to ask a question of Carol as well, about just the concept of shared decision making. Does it mean, I guess, in your experience and in your perspective, does it mean that you'll always be happy with your decision? So does using this process guarantee sort of satisfaction? And I guess related to that is, how do you know when to speak up? Like, how, what are the signs about needing to raise this, how do you know when your treatment might not be working, or to kind of raise or initiate a shared decision-making discussion with your doctor? So there's a double-barreled question there.
Well, I tried to take a note there, so I'll make sure to address both parts of it. And really, this is mainly from my perspective as a patient, a little bit from doing some secondary research on shared decision making. And I will just kind of rehash a little bit of what we said at the beginning of this session, which is that there is research to show that that satisfaction is increased, and that patients do tend to have more confidence and a better working relationship with their doctor. Of course, there's no guarantee, so this wouldn't guarantee that, but it would definitely put the odds in your favor. And you know, that kind of makes intuitive sense, right? You're expressing your wishes, you have more of an active hand in the decision that's made. And it's kind of, to me, it's kind of like you hear that kids who grow their own vegetables are more likely to like the vegetables and to eat them. You know, it's when you're an active participant in the process, it just gives you more of a sense of ownership and a sense that you've really examined the things that matter to you. And I know that's been the case with me. I will say that in terms of my personal experience, I've seen a number of different rheumatologists because I've moved around, so I have a little bit of point of comparison. And sometimes it gets more frustrating if you're working with a doctor who doesn't like to do this, right? Like, this is my recommendation. I don't really want to discuss an alternative. That isn't necessarily the kind of thing that enhances your sense of you know, having a good relationship or being satisfied with the process. But I found that over time, even those people can be broken down a little bit. Seriously. And then in terms of when to speak up, that's a great question. I feel like I'm always speaking up after I get out of the office. I find the office visits are always so rushed. Here especially, I'm in a remote rural area, and it's just an assembly line getting in and out of that office. And I often think of things on the, you know, hour-plus drive home. And so I'm personally, you know, struggling with figuring out how to be smarter quicker when I'm in the office, so I can ask the questions when I have a better chance of getting an answer. But I'm trying to train myself to not give up and getting the answer, to go back and, you know, call back and email or do whatever it is to get my questions, concerns addressed, and not just sort of go, oh, well, I'll wait another 3 months. So I hope that helps.
Yeah, that does. Thank you so much. And as we get close to the top of the hour, I just wanted to give one last opportunity for either of you to make any concluding remarks, and then I have a couple wrap-up bits of information to share, and then we'll conclude. So, Leanna, Carol, any closing comments?
Carol, did you want to say anything?
No, I just appreciate everyone's participation, and nothing further from me.
Yeah, I would like to echo the same. We've done some very rewarding studies with the community at Creaky Joints, and none of this would happen without your interest and your participation. So we're very, very grateful.
Great. Well, thanks very much to both of you. This is wonderful, interesting. Even though I've been involved with these projects along the way, I always learn something new hearing both of you speak. So thank you so much for the time. And as a concluding response to one of the questions, someone asked, is there a way I can participate in future surveys like this or patient symposiums about around topics like these? And one, probably the best way to learn about those opportunities is to, if you're already a Creaky Joints member, that's great. If you want to learn more about Arthritis Power and consider joining that research registry, that's also wonderful, because there's research opportunities that go out to people who are consented participants in Arthritis Power. So that's a great way to do that. And just as a reminder, just to repeat what I said at the beginning of this webinar, this is recorded. We will post it up on our website in the next couple of weeks on Creaky Joints. And so we invite you to re-listen yourself or refer other people to it. And we do these once a month, so we'll send out reminders to everyone about next month's topic, so you'll have an opportunity to join that as well. So again, thank you very much to Leanna Frankel and Carol Wiedmeyer for being such wonderful co-presenters on this topic of shared decision making, and thanks to all of you for joining and being part of the webinar today. Have a great month.
You too. Good night, everybody.
Bye.